Welcome back to the second session of today's symposium. It gives me great pleasure to introduce Kunwar Bhatia, our advanced trainee from the Royal North Shore Heart Valve Center. Kunwar has a keen interest in matters structural and is the inventor of the TABI tracker, an app that we use to keep track of our many hundreds of structural heart patients. Without further ado, I'll hand over to Kunwar, who's going to speak on secondary mitral regurgitation. And Kunwar, please.
Thanks, Peter, and thanks to Structural Heart Disease Australia for inviting me today to talk about essentially secondary mitral regurgitation and transcatheter repair of secondary mitral regurgitation. We're going to see a few cases today in some of the later talks. So this is just a bit of an introduction and an overview of the disease. So the first thing to note is mitral valve disease is common. We always see this slide. We know that the prevalence increases with age. Once you hit the age of 75 and older, the incidence of moderate or severe mitral regurgitation approaches almost 1 in 10 patients. So it's a significant problem. It's the most common valvular pathology that we see in clinical practice. In terms of types of mitral regurgitation, this is always getting a bit more nuanced and a bit more complex. But broadly speaking, there's 2 types of mitral regurgitation. There's a primary mitral regurgitation and secondary mitral regurgitation. So in primary mitral regurgitation, there's a problem with either the leaflets themselves or with the cords. With secondary mitral regurgitation, it's a problem of dilatation of the left ventricle, remodeling of the left ventricle predominantly, and change in geometry. But to make it a bit more confusing, in secondary mitral regurgitation, we've also got this concept now of ventricular remodeling and also atrial. Okay, so this concept also of atrial functional regurgitation. So here's a classic example of secondary mitral regurgitation in diagrammatic format. Here we can see that the LV is being dilated. We can see that there's displacement of the papillary muscle. And the cords remain the same length essentially, right? So if you displace the papillary muscle, you now have tethering of the leaflets. So you've displaced them and you've displaced them into the ventricle. And now you've got failure of coaptation. So this is the most common form of secondary mitral regurgitation that we will see. And when we talk about mitral regurgitation and the different types, secondary mitral regurgitation represents about 2/3 of all isolated moderate or severe MR we see in the community. And within that, left ventricular dilatation represents roughly half of that proportion. And then we've got left ventricular remodeling and atrial annular dilatation, predominantly from AF and flutter. So predominantly today we'll be talking about the secondary, but it's important to note that primary MR is still a problem in and of itself. So transcatheter edge-to-edge repair of the mitral valve. When we talk about this, we have to consider 2 things in broad sense: the clinical and the anatomical prerequisites before you even consider performing the procedure. So when we talk about clinical suitability for the procedure, what are we talking about? The first thing that you need to do is make sure that the patients have been optimized before even considering it, right? So are they on maximally tolerated guideline-directed medical therapy? In the largest trial, or the RCT, comparing the MitraClip to guideline-directed medical therapy, which was a COAPT trial, 90% of the patients were on beta blockers, 2/3 of the patients were on an ACE, ARB, or an ARNI, although only 4% were on ARNI due to the timing of the trial, and 50% were on mineralocorticoid receptor antagonists. So fairly good, guideline-directed medical therapy. Important to also consider cardiac resynchronization therapy if indicated. There's good data out there to show that you can reduce the severity of mitral regurgitation by using cardiac resynchronization therapy. So if your patient is suitable for a BIV, you should definitely consider that as per usual guidelines. And then especially in patients with ischemic cardiomyopathy, treatment of any significant flow limiting coronary artery disease. So these are some of the things that you need to do to optimize the patient before you consider transcatheter repair. And then after you've done that, you should reassess the patient 1 to 3 months down the line and then assess does the patient still have symptomatic heart failure? And do they still have moderate to severe or severe mitral regurgitation? So when we talk about symptomatic heart failure and mitral regurgitation, what are we talking about? So NYHA class 2 or 4A, and at least one heart failure hospitalization within the 12 months or a very, very elevated BNP. These were the criteria that were used in the COAPT trial. And when we talk about grading the severity, there's a lot of ways, if you look at the guidelines, to grade MR. But if we look at the simplest ways, which was used in the COAPT trial, the vast majority of patients, about 85% of patients, were enrolled based on one of two things, essentially. That they had an effective regurgitant orifice area of greater than 0.3 centimeters squared, or they had pulmonary vein systolic flow reversal. And so if you have one of those criteria, then the severity is considered sufficient to be considering this procedure. And the timing of intervention is still very important. So you don't want to wait till it's too late. And what do I mean by that? And we discussed this earlier today as well, was that over time, the ventricle will continue to dilate and you'll continue to get worsening progressive ventricular dysfunction. And you don't want to be at the point where the ventricle is too dilated, too far gone to be intervening. So there is an ideal time for intervention, or an optimal time for intervention, and that's really what we want to focus on. This was discussed in the previous talk as well, this concept of disproportionately severe MR. And this is coming from reconciling the results of the COAPT trial, which showed a mortality benefit, in the MITRA-FR trial, which did not, for transcatheter edge-to-edge repair. And what we saw in the COAPT trial was that the patients had left ventricular end diastolic volumes that were relatively smaller than the MITRA-FR, and they had higher regurgitant orifice areas. So really what it's telling us is you want to pick patients who have disproportionately severe MR when assessing for clinical suitability. So that's a little bit about the clinical suitability. What about the anatomical prerequisites or the anatomical suitability? So in the early days of transcatheter edge-to-edge repair with the mitral clip, there was this idea of optimal valve morphology. So which are the valves that you really want to pick and do, which will be suitable? And the idea was central pathology, so A2, P2 would be ideal. Absence of valve calcification, especially in the grasping zone, so where you're going to be grabbing the leaflets and bringing them together. And we discussed this in the previous talk as well, the importance of having a mitral valve area of greater than 4 centimeters squared at the onset of the case. Having a relatively sizable posterior leaflet, and especially the mobile length of that posterior leaflet, you need at least 7 millimeters, but ideally 10 or more. And the coaptation depth being less than 11 millimeters. So that's the ideal or optimal valve to consider transcatheter edge-to-edge repair. That's not to say that if you don't meet these criteria, you can't do it. Certainly, you don't need A2, P2 lesions anymore. You can go closer to the commissures. You can have, there are operators out there that will operate on a mitral valve area of less than 4 centimeters per squared, as long as the gradients aren't significantly elevated, and special care needs to be taken in those situations. But that tells you a little bit about the optimal valve. Now, where is this all brought together? Normally, there's a heart team approach at a level 1 heart center. So it's very, very important for these patients that a multidisciplinary team assembles to consider the benefits, suitability, and risks for these patients. You do need a lot of expertise, and this is one area of interventional cardiology where you need exceptional interventional imaging expertise, especially in transesophageal echocardiography, to really get the best outcomes for patients. The level 1 heart center should have experience in a broad range of transcatheter and surgical procedures, and there should be the relevant associated support teams. So they're the types of centers that should be doing transcatheter edge-to-edge repair, where they've got all of these facilities and expertise. So in terms of the options, what's available to us for transcatheter edge-to-edge repair, we've got both the MitraClip and the Pascal device available to us here in Australia. And really, it's quite simple. So it's the Alfieri stitch, but in a transcatheter version. So you bring the anterior leaflet and the posterior leaflet together with a clip, And if you place one clip, you get what you see here, which is a double orifice valve. So basically, it's just bringing the two edges of the leaflets together. In terms of the mitral clip, which we have the most experience with, we're now at the 4th generation of the mitral clip. We started off with the classical mitral clip, which you can see on the left, and over generations, it's improved. Currently, what we have available to us in Australia is the 3rd generation mitral clip. And the 3rd generation mitral clip was the first one which included 2 sizing options. So there's the NTR and the XTR. So the XTR is got 3 millimeter longer clip arms, as you can see there, and it's got 3 millimeter longer grippers. And that means that you can grab more of the leaflet, but you do need more leaflet to grasp, obviously, and it increases grasp and reach. We will hopefully soon have the 4th generation, and certainly overseas people do have access to this. And the 4th generation now, instead of having 2 sizes, we have 4 sizes. And essentially what the difference is, we now have wide clips, and the wide clips are 50% wider in the grasping area. So instead of 4 millimeters, there's 6 millimeters. And this is important because it allows you now to be able to pick the valve that's most suitable for the patient's anatomy by having 4 options. It also importantly allows for independent leaflet grasping ability. Now, obviously that won't be your first choice for most procedures, but leaflet insertion optimization is very important, and that's what that enables you to do. And it also gives you left atrial pressure monitoring. So now that we have these 4 types of valves that are going to be available to us shortly, what does that mean? Well, it means that you optimize the clip as per the patient's anatomy. So what do you look at? You look at the leaflet length, you look at the width of the jet, and you look at the mitral valve area. And so for the wide clips, you'd be looking at broader jets and larger valves. And ideally, it will allow you to be able to treat more patients with a single mitral clip, as opposed to needing multiple clips, although you can definitely still use multiple clips. Another option that's available to us, and Peter's going to present a case of this later today, is the Pascal device. So the Pascal device is unique in the fact that it's got this spacer, as you can see there on the right. The nomenclature is a little bit different as you go through the cases, you'll see. Here, it's called, instead of grippers, we've got clasps, and we've got paddles here. The Pascal does have independent clasping already. And hopefully soon we will have the Pascal Ace, which you can see on the left there, which has a much narrower and slimmer profile, and again allows us to treat different anatomies with that. So they're the options that we have in terms of devices. What about the clinical benefit from these devices? So I mentioned it earlier, the COAP trial. The COAP trial was the largest randomized controlled trial of transcatheter edge-to-edge repair with the mitral clip. 614 patients randomized to mitral clip plus guideline-directed medical therapy or guideline-directed medical therapy alone. Remember, all of these patients were optimized prior to being enrolled in the trial, and we saw that there was a significant improvement in hospitalization for heart failure going out to 24 months. The hazard ratio of hospitalization for heart failure was 0.53. with a number needed to treat of 3.1. And if we look at mortality, it showed a mortality benefit as well with a hazard ratio of 0.62 going out to 24 months and a number needed to treat of 5.9. So we saw a significant improvement both in heart failure and in mortality in this randomized trial. Obviously, like with any therapy that we offer our patients, it's not without its complications. And one of the complications to be aware of, and I'm sure will be discussed later today, is the concept of single leaflet device attachment. The incidence rate of this varies from about 1 to 4% in the early days. Now it's probably about 1 to 2%. And so what single leaflet device attachment is when you grasp both the leaflets and then you close the clip, one of those leaflets can essentially come out and you've just got a clip on one leaflet. So functionally, it's not doing anything. It hasn't brought the valves together, but now you've got this leaflet that's sitting there and flapping along. So here in this example, you can see it sitting on the posterior mitral valve leaflet and it's not connected to the AML at all. And if that does occur, you can get a concept known as embolization, essentially if it comes off the other leaflet as well. So this was an interesting case report of a patient who had 4 mitral clips put in at the time of insertion. One was a single leaflet device attachment. and then 12 months later, had some arm pain and some heart failure, and noted that a clip had embolized to the axillary artery. So it's extremely rare, but it does happen. And there have been case reports of it embolizing to things like the right coronary artery as well. Another thing to think about, and I'm sure that will be discussed later today again, is what about residual MR? So every time you put in a clip, you hopefully reduce the mitral regurgitation, but there is often some mitral regurgitation left at the end of the case. And so this is data directly from COAPT, and we can see that the majority of patients had 0 or 1+ mitral regurgitation at the end of the case, but about 7% of patients had 3+ or more mitral regurgitation at the end of the case. And what does that mean? Well, if we look at the trial, although the patient numbers in the 3+, 4+ group are reassuringly low, we can see that outcomes are significantly worse in those patients. So the time to death or heart failure hospitalization is significantly worse in patients who have got 3+ or 4+ mitral regurgitation at the end of the case, which just reinforces the importance of ensuring that adequate treatment of the mitral regurgitation is done at the time of the case. And so really, what are the key messages or the take-home messages from this, essentially about edge-to-edge repair of secondary mitral regurgitation? The first key message is secondary mitral regurgitation is common, especially in patients aged over the age of 75. Prior to even considering transcatheter edge-to-edge repair, you need to make sure that the patient is optimally managed. So you need to make sure they're on maximum tolerated guideline-directed medical therapy, if appropriate for CRT, that has been considered. And if they've got flow-limiting coronary artery disease, which is significant, that has been treated as well. Then you need to consider the anatomical suitability, and this is something that very much the heart team will do, which is, in most cases, avoiding perforated or cleft leaflets, significant calcification in the grasping zone, avoiding mitral stenosis, so patients who have a mitral valve area of less than 4 at the onset of the case or any significant gradient, avoiding cases where short mobile length of the posterior leaflet, less than 7 millimeters. And then in those cases where you have the anatomical suitability and the clinical suitability in the appropriately selected patients, transcatheter edge-to-edge repair is associated with reduced mortality and hospitalization for heart failure. And that's it. Thank you.
Thank you, Kunwar, for an excellent presentation on secondary mitral regurgitation. And I would like to remind you just to continue to ask questions via the Q&A function on your screen. It's going to make for a much better meeting the more questions we have from you. And there will be a 20 or 30-minute Q&A session at the end of the meeting today with an expert panel, as I said earlier. At this point, I'd like to welcome our delegates from Western Australia, from Perth, from Fiona Stanley. Welcome and thank you for joining us today. And next, we have a series of 3 cases of mitral valve, of treatment of mitral regurgitation. The first case is by Associate Professor Martin Ng and his team from Macquarie University Hospital. And I will now hand over to Martin, who will introduce his team and the case, and we will then join them at the heart team meeting. Over to you, Martin. Thank you.